Welcome back to the Deep Dive. Today, we're really getting into the weeds of radionuclide bone scintigraphy.
Yeah, it's one of those workhorse techniques, isn't it?
Absolutely. And for you, our listener, the radiologist, interpreting these complex hybrid studies day in, day out, we want to go beyond just a review.
Oh.
We're aiming to really synthesize what you need to know about the pitfalls, the normal variants that look like something nasty, artifacts, and, the whole SPECT-TCT versus FDG PET question, especially for things like infection and painful joints.
Right. We're drawing on recent reviews, guidelines covering conventional scans, SPECT-TCT, focusing on those technical bits and diagnostic gray areas that honestly demand really rigorous interpretation.
Our mission, then, is to distill these patterns, these artifacts, the emerging standards, all to help sharpen that diagnostic edge.
And it boils down to that central paradox of bone scans, doesn't it? Fantastic sensitivity. I mean, you can see changes months before plain films sometimes.
Well, yeah.
But then, bam, the specificity often just isn't there. Which means you absolutely need that deep technical and clinical knowledge to avoid misreading things.
Exactly. Seeing the hotspot is step one. Knowing what it is.
Yeah.
That's the real skill. If you don't know what's normal or benign, everything looks suspicious, and that leads to unnecessary workups, costs, anxiety.
Precisely.
So let's try and provide that shortcut to expertise today. Okay, let's start right at the beginning. The core mechanism. We're mostly using technetium-99 labeled diphosphonates, MDP, HDP, HMDP.
Right.
What's actually happening at the bone surface? What drives that tracer uptake? And how does the body's physiology play into it?
Fundamentally, it's chemisorption. The diphosphonates, being phosphate analogs, stick onto the bone surface. But it's driven by two key things physiologically. Local blood flow, got to get the tracer there, and osteoblastic activity. That determines how much gets pulled out of the blood.
So more bone turnover, more uptake.
Exactly. They adsorb directly onto the hydroxyapatite crystals, specifically onto the active surface where mineralization is happening. It's actually the immature, sort of amorphous calcium phosphate surface before it fully locks into that crystalline hydroxyapatite structure.
Interesting. And since it's an IV injection, the timing, the pharmacokinetics, that's everything for image quality, right? Getting good bone-to-background contrast.
Absolutely critical. You need the unbound tracer to clear out of the soft tissues. The kinetics are pretty quick. Peak bone uptake happens around an hour after injection.
Just 1 hour.
Yeah, and it stays pretty constant after that, sometimes for days even. But the key is clearing the background. If you have normal kidneys, about 60% of that unbound stuff is gone by 6 hours.
Which is why we image when we do.
Precisely. That 2 to 5 hour window post-injection is standard, aiming for that sweet spot where bone uptake is high and background is low enough.
Okay, but what if things aren't standard? Patient with bad kidneys, or maybe you're looking at the pelvis and the bladder's just full of hot urine right over the area of interest.
That's when you absolutely have to go to delayed imaging. If the kidneys aren't clearing the tracer well, you wait longer. 6 hours, 12, sometimes even 24 hours.
Oh, 24 hours.
Yeah, you need to give the body time to clear it through other routes or just dilute it enough so the background drops. And for the pelvis, that bladder is a major problem. It can totally hide the pubic symphysis, SI joints, proximal femora.
So delayed imaging helps there too.
Delayed imaging, sometimes getting the patient to void right before, bladder catheterization in some cases, or increasingly relying on SPECT-TCT to just anatomically separate the bladder activity from the bone.
Right, SPECT-TCT. That brings us to the evolution. We went from spot views to whole body scans with multi-headed cameras, which was a big jump in efficiency and resolution.
Huge jump.
But adding SPECT and then SPECT-TCT.
That was really about tackling the specificity problem head-on, wasn't it? Exactly. Planar imaging is just inherently limited by overlapping structures. Kidneys over ribs, bladder over pelvis. SPECT-T helps with relocalization and contrast. But SPECT-TCT, fusing the functional data with the CT anatomy, that's the real game changer. It lets you see exactly where that hotspot is located anatomically and helps characterize it. Is it in the facet joint? Is it in the pedicle? That makes all the difference.
Let's talk about one pattern that really highlights the sensitivity specificity issue, the super scan. You see that image, bone uptake everywhere.
Right.
The immediate thought is often Mets, right?
It is. It's a striking pattern. The skeleton is just so avid for the tracer, it sucks almost all of it out of the blood.
Right.
So you get two main features. One, this diffuse, often dramatically increased uptake throughout pretty much the entire skeleton. And two, because the bone is taking it all, you see very little, sometimes almost no activity in the soft tissues, the kidneys, or the bladder.
The kidneys might look faint or absent.
Exactly. The bone just outcompetes the normal clearance pathways.
So, faced with that pattern, How do you, as the expert interpreter, start to differentiate between a malignant cause, widespread mets, and something like severe metabolic bone disease, say renal osteodystrophy? That distinction is critical.
It is. You look for subtle clues in the pattern and distribution. A malignant superscan, often from prostate, breast, or lung cancer, while diffuse, might have a slightly more irregular or heterogeneous look. And critically, you might still be able to pick out some more focal, intense hot spots superimposed on that diffuse background, maybe in the ribs, ends of the long bones, or the extremities. Those are your established metastases showing through.
Okay, and the metabolic superscan.
That tends to be more intensely uniform and symmetric. Think severe renal osteodystrophy or maybe hyperparathyroidism. A key sign there is often really intense uptake in the skull vault, the calvaria, that can be disproportionately hot in metabolic disease.
Ah, the calvaria. Good tip.
Also, sometimes you see increased uptake at growth plates if they're still active, or other high turnover areas like the sternum can be particularly prominent.
Okay, moving from diffuse patterns to tricky focal findings. This is where knowing your normal variants and benign mimics is absolutely crucial. Let's start with a classic headache. The solitary rib lesion in a patient with known cancer.
Oh yeah, the solitary rib lesion. It's a minefield partly because the older literature could be, well, kind of reassuring. Some early studies suggested maybe only 10% were malignant.
Right, I remember those figures.
But more recent data, like what we're drawing on here, paints a much scarier picture. Some reports show malignancy rates up to 41% for a single, unexplained rib hotspot.
41%, wow.
And it gets worse. Even focal uptake just at the anterior rib ends, the costochondral junction area, which people often dismiss as trauma or degeneration. One study found malignancy there in 36% of cases.
So that old rule of thumb about anterior end is probably benign is dangerous.
Very dangerous. You cannot rely on location alone. What you do need to look closely at is the morphology. A linear pattern, something extending along the rib shaft, maybe parallel to it, that's highly suspicious. That's much more likely to be malignant or a pathological fracture than, say, a more focal, rounded spot from a simple traumatic fracture.
So line bad, focal, investigate further.
Pretty much. Any solitary focal uptake needs correlation, usually CT.
Okay, shifting to the spine. Especially in older patients, it's just full of degenerative changes that can light up. What about a single spinal hotspot in someone with a known primary cancer?
Extremely challenging on planar imaging alone. The prevalence of degenerative joint disease, facet arthropathy, osteophytes, it's so high. There was a study that followed patients with a known primary and just one spinal hotspot. On follow-up, over half, 57%, turned out to be benign.
More than half.
Yeah, it just hammers home that planar imaging, even SPECT sometimes without the CT, often isn't enough to make the call definitively in the spine.
And vertebral compression fractures. They're common, too. Osteoporotic ones often have that typical horizontal linear band of uptake. Does that help distinguish them from malignant collapse?
On planar, it helps a bit, but it's not foolproof. That linear pattern is characteristic of a benign fracture, sure, but malignant fractures can sometimes look similar initially. What helps more is the time course, and again, where SPECT-TCT becomes invaluable. Benign fracture uptake usually peaks and then fades over 6 to 12 months. Malignant involvement tends to persist or even increase.
And location clues.
Yes. Malignant collapse is more likely to involve the posterior elements, especially the pedicle, or you might see a more focal, destructive lesion within the vertebral body itself, rather than just that uniform band of a simple compression. But again, SPECT-TCT is often needed to see that clearly.
Right. Let's catalog some of those benign variants we absolutely have to recognize. Starting up top, in the head and neck.
Okay, skull. You often see increased uptake at suture lines, where the bones fuse. Also common at the pituitarian, that junction on the side of the skull, and the occipital protuberance at the back.
And that can be more marked in metabolic disease.
Yes, definitely. Things like renal osteodystrophy can make those sutures really pop. Also, you see age-related thickening of the frontal bone, hyperostosis frontalis interna. That shows up as mild, usually symmetric uptake along the inner table of the frontal bone. Benign finding.
And the opposite, a cold spot in the skull.
Parietal thinning. Yeah, that can catch people out. It looks like a photopenic defect, an area of decreased uptake in the parietal bone region. Can be symmetric or asymmetric.
But it's just thin bone.
Exactly. Normal aging change, zero clinical significance. But if you're not aware of it, you might worry about a gallitic lesion.
Good one to know. Moving down to the thorax. Lots of degenerative potential there.
For sure. The manubriosternal junction, the angle of Louis, often shows increased uptake. Usually just degenerative change or chronic microtrauma. considered normal. Symmetric uptake in the sternoclavicular joints or the acromioclavicular joints out of the shoulder, almost always just plain old degenerative arthritis.
But the sternum itself needs careful scrutiny, especially with breast or lung cancer history.
Absolutely. It's a common site for METs. You worry about malignancy if a sternal lesion is clearly away from that manubriosternal junction, if it looks irregular, if it's off to one side, eccentric, or asymmetric compared to the midline.
And another photopenic pitfall here, the sternal foramina.
Yes, these are important. They're basically holes in the lower sternum where the cartilaginous bars didn't fully fuse during development. They show up as small, cold spots, photopenic defects, usually surrounded by normal sternal activity. You must recognize these as normal variants, non-ossified tissue, and not mistake them for lytic lesions or some kind of artifact.
Okay, finally in this section, let's cover two specific benign syndromes with really characteristic scintigraphic looks.
Right. First, HPOA, hypertrophic pulmonary osteoarthropathy, classically associated with lung cancer, especially bronchogenic carcinoma. The hallmark is this distinct, symmetrically increased linear uptake along the cortex of the long bones. Gives you that classic tram line or parallel track appearance. You see it most often in the femora, tibiae, maybe radius and ulna wrists. Very specific look.
Tram lines, got it. And the second?
RSD reflex sympathetic dystrophy, or CRPS, complex regional pain syndrome. The classic bone scan finding, especially in the early acute phase, is diffusely increased uptake throughout the affected limb, particularly around the joint's periarticular uptake. Usually spares the joint surfaces themselves, reflects that intense inflammation and increased blood flow.
So a hot hand or foot?
Typically, yes, but there's a caveat. While hot is classic, you can sometimes see normal or even decreased uptake, particularly in kids or in the later chronic stages of the disease. So absence of the hot pattern doesn't rule it out completely.
And all this ambiguity we've been discussing, especially in places like the spine, is exactly why SPECT-TCT has become so indispensable. It directly addresses that high false positive rate from degenerative changes. How exactly does seeing the CT fusion help definitively characterize a spinal hotspot?
It moves you from just seeing activity to understanding the architecture of where that activity is. The fused data lets you pinpoint the uptake. Is it truly within the vertebral body? Is it extending into the posterior elements? Is it involving the pedicle?
And those locations matter.
Critically, lesions that clearly extend from the body back into the posterior elements or directly involve a pedicle, those structures are rarely involved by simple wear and tear degenerative changes. So uptake there is much more suspicious for metastasis.
Versus benign locations.
Right. If the uptake is strictly confined to a facet joint, or maybe just on an anterior osteophyte on the vertebral body, or clearly related to either side of an intact disc space, those patterns are overwhelmingly likely to be benign degenerative processes. SPECT-TCT lets you make that distinction with much higher confidence.
But like any advanced technology, it comes with its own set of potential problems. Technical pitfalls. Misregistration seems to be the big one for SPECT-TCT. We need to understand why it happens and, more importantly, what it looks like on the images we interpret.
It's definitely the most common major artifact, the Achilles heel, if you like. It can happen for mechanical reasons. The SPECT cameras and the CT scanner aren't perfectly aligned. Their centers of rotation are off. Maybe the couch moves or sags slightly between the scans.
Or the patient moves.
That's the most frequent cause, patient movement, whether voluntary or involuntary, between the SPECT and the CT acquisitions.
And the impact. Why is that misalignment so bad?
Because the whole point of the CT in SPECT-TT is to provide an attenuation map. It tells the reconstruction algorithm how much tissue the SPECT photons had to travel through. If the patient moves, the CT map you apply is now incorrect for where the SPECT photons actually came from.
So the correction is wrong. What does that look like?
Two main problems. First, localization errors. A hotspot might look like it's outside the structure it's actually in on the fused image. Second, and more subtly dangerous, is attenuation correction failure. You see it most clearly at sharp boundaries, like the edge of an organ or bone. The wrong correction factor gets applied. It can overcorrect, creating a fake hotspot where there isn't one. Or it can undercorrect, making an area look falsely cold, potentially hiding a real lesion or mimicking pathology like an uptake defect. It really undermines your confidence.
And then there's the breathing issue. CT is super fast, maybe a breath hold. SPECT takes, 15, 20 minutes?
Exactly. Big mismatch.
So how do you interpret activity near the diaphragm, lungs, heart, knowing the patient was breathing normally during the long SPECTA scan but held their breath for the CT?
That's a major challenge in the chest and upper abdomen. You acquire the CT map in one snapshot of the respiratory cycle, let's say end expiration, but the SPECT data is averaged over many, many breaths during those 20 minutes. The diaphragm, heart, lungs, they've all moved up and down. So when you fuse them, you get this inherent positional mismatch, this local misregistration. It blurs boundaries, makes it really hard to be sure if a lesion is truly in the lung base, the liver dome, or the chest wall.
Okay, what about hardware artifacts? Metal implants, pins, joints, even dental fillings. They cause havoc on the CT, right? And that must mess up the SPECT correction.
Big time. Highly attenuating stuff like metal causes massive streak artifacts on the CT reconstruction. It essentially creates black holes or areas where the scanner gets zero photon counts.
Because the X-rays just can't get through.
Right. So the CT reconstruction algorithm fails badly in those areas, producing nonsensical Hounsfield units. And since the SPECT relies on that flawed CT map for its attenuation correction...
Garbage in, garbage out.
Precisely. The attenuation correction applied to the SPECT data near the metal will be totally wrong. You often see artifactual hot or cold spots right next to the implant, which obviously makes it incredibly difficult to assess for things like periprosthetic infection or loosening accurately.
Lastly, on artifacts, let's touch on dose and noise. SPECT TCT often uses lower CT dose settings than a standalone diagnostic CT, partly for LER principles, diagnostic reference levels.
Correct. We try to keep the CT dose low since it's primarily for localization and attenuation correction.
But there's a trade-off, isn't there? Especially in larger patients.
Definitely. Lowering the CT tube current, the MAA, directly increases image noise. It reduces the signal-to-noise ratio. This is much more noticeable in bigger patients. That noise can manifest as more streaking artifacts, and it just generally degrades the CT image quality, making it harder to see fine anatomical details. It can be harder to confidently localize small lesions or assess complex areas like the spine or pelvis.
And with very low doses.
With ultra-low dose protocols, especially if using certain reconstruction methods, you also risk truncation artifacts if the patient is large and parts of their body, like their arms, fall outside the CT scanner's field of view. The system can't accurately map the density there, leading again to errors in the attenuation correction for the SPECT-T.
Okay, let's pivot now to infection. Musculoskeletal infection. This is where the non-specific nature of the standard bone scan really becomes a limitation. Sensitive, yes, it shows increased turnover and osteomyelitis, but tells you nothing about why.
Exactly. The bone scan lights up, but is it infection, trauma, inflammation, tumor? It can't tell the difference reliably.
And the traditional alternative, labeled white blood cell scans, they have their own issues, right?
They do. Labeled leukocytes are highly specific for acute bacterial infection, which is great. But they have two major drawbacks. First, poor spatial resolution. It's often hard to tell if the activity is truly in the bone versus just in the adjacent soft tissue. Second, and this is a big one, their sensitivity for chronic osteomyelitis, especially in the spine, the axial skeleton, is really quite poor, sometimes as low as 21%.
21%. Why so low in the spine?
It's because of the normal background activity. The axial skeleton contains a lot of active hematopoietic bone marrow, and labeled white cells can accumulate physiologically in marrow. So trying to see a subtle chronic infection against that relatively high background uptake is very difficult.
Which is where FDG-PCTT comes in strongly.
Right. FDG-PTT has really emerged as the superior tool for confirming or ruling out low-grade or chronic osteo, both in the axial skeleton and peripherally. It leverages the increased glucose metabolism of inflammatory cells, neutrophils, macrophages, lymphocytes.
And the workflow is faster, too.
Much faster, usually done within an hour or so after injection. Plus, it gives you high target-to-background contrast.
The accuracy numbers are pretty striking for chronic osteo.
They really are. Studies often report sensitivities close to 100% and specificities up around 99%. And crucially, the CT part of PTCT provides that precise anatomical localization. It lets you definitively say, yes, this abnormal FDG uptake is within the bone, or no, it's confined to the overlying soft tissues. That's a distinction the old planar white cell scans really struggled with.
Now let's talk about hardware again. FDG-PTTC seems to perform particularly well when there's infection around trauma implants, like plates and screws. Why is that? And how does it contrast with prosthetic joints?
Good question. It works well with trauma hardware, like internal fixation devices, because the materials typically used, often titanium alloys. Relatively slender implants tend to cause fewer metal artifacts on the CT component of the PTCT compared to big, bulky hip or knee replacements.
Fewer artifacts mean better localization.
Exactly. You get a clearer anatomical picture to fuse the PET data onto, making it easier to assess infection around those implants.
But then you get to total joint replacements, arthroplasty, and suddenly the utility of FDG-PET becomes much more debated.
Highly debated. And the reason is fundamental. FDG accumulates in response to any significant inflammation, any high glucose metabolism. In a painful prosthetic joint, yes, you might have infection, but you also very commonly have significant inflammation purely from aseptic loosening the body, reacting to where debris particles, micromotion at the implant interface.
Sterile inflammation.
Precisely. And FDG lights up for both the bugs and the sterile reaction to debris or movement. It can't reliably tell them apart based on uptake intensity alone. That lack of specificity in the prosthetic joint setting is its major downfall and pushes us towards a different nuclear medicine approach.
Which brings us squarely to that critical everyday scenario, the painful hip or knee replacement. Figuring out if it's aseptic loosening or infection is paramount. The treatments are totally different. Revision for loosening versus massive surgery, long-term antibiotics for infection.
Huge implications. And the standard clinical stuff, patient symptoms, basic labs like ESR, CRP, they're often non-specific. They might be elevated in both conditions. Nuclear medicine is often asked to provide the definitive answer.
We know the standard bone scan isn't the answer here. It's sensitive, sure, it'll show increased activity around a failed prosthesis.
Right, it tells you the joint is unhappy, there's increased bone turnover around the components.
But it's terrible at telling you why it's unhappy. Accuracy for differentiating infection from loosening is often quoted around 50–70%, basically a coin toss.
Pretty much useless for that specific question.
People tried, didn't they? Looking at the pattern of uptake, was it focal at the tip or stem, suggesting loosening, versus diffuse, suggesting infection?
Yeah, there were early attempts to differentiate based on the distribution of the increased paraprosthetic uptake. The hope was that focal uptake might mean mechanical loosening, while diffuse uptake might mean infection.
But it didn't pan out.
No, it proved inconsistent and unreliable. Larger studies showed that diffuse, intense uptake around the prosthesis could be seen in both aseptic loosening and definite infection. The underlying inflammatory processes, whether sterile or septic, just look too similar on a standard bone scan.
Even adding the blood pool phase, the 3-phase bone scan,
only offered minimal improvement. Maybe bumped the accuracy up slightly to around 62% in some studies, but still nowhere near good enough to confidently guide major surgical decisions.
Okay, so if bone scan fails and FDG-PET fails due to non-specific inflammation, we need something that specifically targets the infection process, the host immune response to bacteria, while ideally ignoring that background aseptic inflammation.
Exactly. And that's why combined labeled leukocyte marrow imaging emerged, and still remains, the nuclear medicine gold standard for diagnosing prosthetic joint infection.
The combined study, let's unpack that. Accuracies are reported up to 95%.
Yes, when performed and interpreted correctly, it's highly accurate. It works because it's comparing the distribution of inflammatory cells, leukocytes, to the distribution of the patient's normal bone marrow.
So, 2 separate scans, essentially.
Correct. First, you do a labeled leukocyte scan, usually using indium-111 or technetium-99-medi HMPAO labeled white cells. This shows you where inflammation and infection are pooling the white blood cells. Then you do a bone marrow scan, typically using technetium-99-medi sulfur colloid. Sulfur colloid particles are taken up by the reticuloendothelial cells in the bone marrow. So this scan effectively maps out where the active hematopoietic marrow is located around the prosthesis.
And the interpretation hinges on comparing those 2 maps.
Precisely. It's all about spatial congruency. In a joint that's normal or one that has only aseptic loosening, the inflammation is generally confined to the areas where the marrow is reacting to the implant. So the leukocyte activity and the marrow activity maps will look the same. They'll be congruent.
The white cells are where the marrow is.
Right. But if there's a true bacterial infection, the neutrophils and other inflammatory cells migrate beyond the normal marrow space. They go to where the bacteria are. So infection is indicated when the leukocyte activity extends significantly beyond the marrow activity or is in a pattern clearly different from the marrow distribution. That's incongruent uptake.
So the incongruity is the key sign of infection.
That spatial difference is what allows the test to distinguish infection from the background inflammation of aseptic loosening, which typically stays congruent with the marrow pattern.
Okay, let's circle back to FDG Barrett one last time in this context.
Yeah.
Given how good it is for osteo elsewhere, why are we still so hesitant to replace the leukocyte marrow scan with FDG PAT for prosthetic joints? You hear people debating it.
The debate continues, but the fundamental problem remains specificity. Yes, FDG-PTT is very sensitive. It will almost certainly light up if there's any problem, infection or loosening, but it lights up because both conditions involve metabolically active inflammation. As we said, FDG accumulates in the inflammatory cells associated with infection and in the inflammatory response to wear debris and micromotion in aseptic loosening.
So uptake alone doesn't help. What about intensity? Is infection hotter?
Generally, no.
Sure.
Attempts to use SUV max thresholds or other quantitative measures haven't proven reliable or consistent across studies. Some researchers have looked at patterns like activity specifically along the bone prosthesis interface being more suggestive of infection, but even that isn't robust enough yet.
So not ready for prime time as a replacement.
Not as a replacement for leukocyte marrow imaging when the specific question is infection versus aseptic loosening. The potential for a false positive, calling loosening infection, or false negative missing infection, is just too high with FDG-PET in this specific high-stakes scenario, given the consequences of misdiagnosis. The spatial information from the marrow scan remains critical.
Okay, we've diagnosed the patient. Now we have to communicate the findings. Let's shift to the final product, the report. For you, the radiologist signing these out, a clear, structured report isn't just nice to have. It's essential for quality, communication, safety.
Absolutely non-negotiable. Guidelines consistently emphasize using a structured format. It ensures consistency, makes sure key elements aren't missed, and helps the referring clinician quickly find the information they need.
So what are those essential components of a good nuclear medicine report, especially for bone scans?
You need the basics, of course. Patient details, study date, then, critically, the indication why was the study done. A concise but complete description of findings. What did you see? Where? This should include relevant technical details. Then the crucial parts. Your opinion or impression, is it normal, abnormal, a variant? If needed, recommendations for correlation with other imaging or clinical findings. And importantly, if it's abnormal, a comment on the likely significance or the most likely underlying condition.
Prognostic information too sometimes.
Yes, where applicable. For example, commenting on the extent of metastatic disease burden might have prognostic value.
The source material makes a useful distinction between the technical parts of the report and the clinical conclusion. How do we balance providing necessary technical detail without obscuring the main message for the clinician?
That's key. The technical domain covers the how. The radiopharmaceutical used, e.g. 559 MBQ of TC99 media HDP. The route, IWV, the acquisition details, delayed whole-body images, SPECT TCT of the lumbar spine with low-dose CT for attenuation correction and localization. These details are vital for quality control, audits, and comparing with future studies.
But the clinician needs the what up front.
Exactly. The clinical domain synthesizes all that technical data and observation into a clear, actionable conclusion. That's your opinion on normalcy, your interpretation of the findings in the clinical context provided, and your final comment on significance.
So the ideal report structure kind of blends them. A clear conclusion followed by the technical supporting details.
That's generally best practice. Start with the conclusion or impression, so the referrer gets the main message immediately. Then follow with the detailed description and necessary technical parameters. This ensures the clinical takeaway is prominent, but the supporting data is still there for reference, for follow-up, for the record.
Makes sense. You don't want someone having to wade through matrix sizes to find out if the scan shows METs.
Precisely.
Finally, a critical aspect of reporting. Managing critical or unexpected urgent findings. There are formal procedures for this now, right? Patient safety alerts, like the NPSA Alert 16 in the UK.
Yes, this is incredibly important. If you identify a critical finding, something life-threatening or requiring urgent intervention, like maybe unsuspected extensive METs causing cord compression risk, or a PE on a VQ scan done for other reasons, you have a responsibility beyond just dictating the report.
What does that process involve?
It's usually a multi-step process defined by local policy, but generally includes: first, flagging the report as urgent in the dictation system, maybe starting the report with a standard phrase like urgent finding. Second, and most importantly, direct communication. You need to contact the referring clinician or an appropriate clinical representative directly, usually by phone, to convey the critical information immediately. Don't just rely on the report hitting their inbox eventually.
And documenting that communication is key.
Absolutely essential. The final step, often overlooked but critical for medico-legal reasons and closing the loop, is to document in the report itself that you made direct contact, who you spoke to, and when. For example, Findings verbally communicated to Dr. Jones, orthopedic registrar, at 15:30 on 2025-11/09 due to suspicion of impending pathological fracture. That creates a clear audit trail. Hashtag tag outro.
Well, this has been quite the journey through bone scintigraphy, from the chemistry of diphosphonate binding all the way to the formalities of reporting critical results.
We've covered a lot of ground. I think the core message, hopefully clear to you, our radiology colleagues listening, is really about pushing past the sensitivity and mastering the specificity.
Key takeaways seem to be: SPECT TCT is invaluable for nailing down those ambiguous spinal lesions, especially looking at posterior element or pedicle involvement.
Right. And understanding the specific strengths and weaknesses of different techniques for infection, FDG PT shines in chronic osteo, especially axial, but for prosthetic joints. That combined leukocyte marrow scan is still the undisputed king because of the congruency principle.
And of course, just having that mental catalog of the mimics and pitfalls, knowing the high risk of malignancy in solitary rib lesions, recognizing benign things like sternal foramina or HPOA tram lines, and being aware of artifacts like respiratory misregistration on SPECT TCT.
Exactly. Building that internal library of what isn't pathology is fundamental.
So let's end with a thought to chew on. We're constantly pushed to reduce radiation dose, using low-dose CT for SPECT TCT. But we also know that sometimes, especially in really complex cases, having better anatomical detail from a higher quality diagnostic level CT might actually improve our specificity and confidence more significantly.
It's a real tension. The drive for low dose versus the need for definitive anatomical correlation.
So the provocative question for you to consider is, how will future guidelines and practice evolve to balance these competing demands? Will we see more tailored protocols, maybe using diagnostic CT settings in specific scenarios like complex spinal cases or paraprosthetic evaluations, even if it means a higher dose for that particular study because the diagnostic gain outweighs the risk? Or will the push for ultra-low dose prevail across the board?
Finding that optimal balance between dose reduction and diagnostic certainty, especially with hybrid imaging, that's likely going to shape how we practice bone scintigraphy for the next decade.